Welcome, everyone. Thank you for joining us for our first Newborn Toolkit webinar in 2025. This is a leading change at hospital level, building strong teams for vulnerable newborns webinar. Welcome. Please introduce yourself in the chat. Next slide, please. Welcome, everyone. The Newborn Toolkit aims to move faster together as a multilingual, multi-country learning platform for small and sick newborn care. In 2024, we had over 55,000 unique users from over 170 countries. And it's all thanks to our community of practice globally that continues to make use of the Newborn Toolkit. The Newborn Toolkit has over 1,000 tools in 15 languages, technical content in French, and linked communities of practice in English and French, such as this webinar we're on today. Next slide, please. So what is the Newborn Toolkit? Our implementers globally have defined this toolkit in very interesting ways, such as Robert Taylor, who defined the toolkit as a supermarket for small and sick newborn care resources, and Dr. Msandeni Chiume, who defined the toolkit as having the bits and pieces for what you need to make newborn care work. Next slide, please. So once again, welcome to our implementation learning seminar series to move faster together. Leading change at hospital level, building strong teams for vulnerable newborns is today's topic, and we have an amazing lineup of experts in the field of neonatal care. So on the screen now, you see QR codes to our newsletter in French, our newsletter in English, and QR codes for our social media channels on X, Twitter, LinkedIn, and Facebook. Next slide, please. So our upcoming Newborn Toolkit webinars are many and interesting. On the 18th of February, we have a topic on newborn care. Is newborn pain care a luxury in high burden contexts? And on 18th March, we have a webinar planning the right devices and how to keep them working for newborn care. And now I'll hand over to my colleague, Lauren. Next slide, please.
Merci. Alors, bonjour et bienvenue à tous les participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez le canal de traduction affiché en bas de l'écran. On a aussi quelques webinaires à venir. Le 18 février, la prise en charge de la douleur de nouveau-né est-il un luxe dans les pays à fardeau élevé? Et le 18 mars, planifier les bons dispositifs et comment les maintenir pour les soins en nouveau-né. Alors, nous vous invitons de nous rejoindre pour ces webinaires. Next slide, please. And we are very excited today to have Dr. Natasha Rhoda as the host of the webinar. She's a neonatologist with 3 decades experience as a clinician and has occupied both provincial and national newborn care advisory posts in South Africa. Dr. Rhoda is well known in the global newborn care community and has been instrumental in teaching and training neonatal fellows for sub-Saharan Africa via the African Pediatric Fellowship Program. Until December 2024, she was the head of the clinical unit at Mowbray Maternity Hospital and maintains an affiliation with the University of Cape Town. Dr. Rhoda recently joined the NEST 360 as a neonatology domain expert. So we're very excited to have Dr. Rhoda, and thank you for being our fabulous host today.
Thank you. 3 weeks into the job. Very happy to join, and thanks for that introduction, Lauren. So this is our first series on the toolkit, and our topic today, as you've heard, is all about building stronger teams. And our panelists, I can tell you, are representing 3 continents. And I'll start off with the first one right here in Africa, and that would be Professor Victor Mwapasa. The second talk is going to be given, so thanks. That's fine, you can go ahead. The first talk is by Professor Victor Mwapasa, and Prof. Victor is a public health expert, a research scientist, and professor at the University of Malawi College of Medicine. He's also previously served in many senior positions at the College of Medicine and includes the Associate Director of the Malawi Liverpool Wellcome Trust Clinical Research Program. He's the Director of the Research Support Center, the Head of the Department of Public Health, the Dean of the Postgraduate Studies and Research, and also the Chairperson of the College of Medicine's Research and Ethics Committee. Prof. Victor, over to you, and thank you for joining us on our first seminar this year.
Thank you very much. Just as a matter of clarification, my institution is Kamuzu University of Health Sciences in Malawi and not University of Malawi. Next slide, please. Next slide. In an effort to improve people's health status during the Millennium Development Goal era, national and global policies focused on improving people's access to care. But it soon became apparent in the Sustainable Development Goal era that improving access is not adequate. You have to improve the quality of services that are being delivered. In actual fact, poor quality of care accounts for so many millions of deaths in low and middle income countries. And as you know that for neonates, poor care is very bad as they are very vulnerable. In low and middle income settings, there's strong evidence that health technology, specific interventions such as health technologies, medical training, and clinical audits improve clinical outcomes. But less research attention has been given to broader organizational factors that are necessary to support the delivery of health services. And these are important because they sustain the health system beyond individual projects that provide technologies, training, and clinical audits. Next slide. Actually, studies from high and upper income countries have found mixed results on the association between hospital management practices, which is a form of governance, and improved clinical outcomes. And I must say that most of these studies come from these high and upper middle income countries. Most studies show that improved management actually can lower all-cause mortality, fewer deaths from myocardial infarction, and fewer deaths from surgery. But this is not unanimous because some studies, particularly in the US, have shown no evidence of the association between management scores and mortality. However, when you go to low and middle income countries, particularly low income countries like Malawi, few studies have analyzed the association between management and mortality. In actual fact, available evidence focuses on the association between management and processes of care, such as adherence to treatment, case management, but not on hard outcomes such as mortality. Next slide. When you think about the term management, people can be confused, but it has been defined as continuously developing the potential of an organization to transform human and financial resources and other inputs to improve services and guarantee better health. A key challenge is that although this definition looks good, is how to quantitatively measure management. This has been a problem, and this has actually affected any research connecting management and quality of care and even mortality. But recently, researchers, including our own, have actually conceptualized a management approach to measuring management, and basically focused on the adoption of a set of management practices. So they will define required management practices and measure them. So now it is possible to measure management practices. Next slide, please. When you look at the Malawi, the trend of neonatal mortality, just to demonstrate the point that I've shown that neonatal mortality rate has been going down, mostly due to improved access to health services for the neonates. But if you look on the right of this graph, the last measurement of neonatal mortality was 19 per 100,000 live births. But to improve to 12, which is the target in 2029, there is indeed a need to improve the quality of care beyond improving the access to care. Next slide. So we have developed actually through the project that we are running called the Innovative Management Practices to Enhance Hospital Quality and Save Lives in Malawi, in short, the IMPRESS study. We have devised a way of measuring management practices, and basically these cover 5 domains that are listed there: leadership and governance, human resource management, target setting and monitoring, delivery of clinical care, and financial management. And in each of these domains, there are set practices that we discussed with health providers, and they agreed that they're important for improving the quality of care. So we are able to measure the level of implementation of these 28 management practices. And the way we measure it is that people ask questions to healthcare providers and managers, and then make a judgment on a level of 1 to 5 as to the level of implementation of these management practices. Next slide, please. And our preliminary study done in 2002 in 36 hospitals. Next slide, I hope you're on the next slide. In 36 hospitals in Malawi, showed a varying performance. I hope you can hear me. Okay, varying performances of various health facilities. As you can see here, we have actually ranked 36 facilities, and you can see that the average score of management practice implementation is 3.35, and with a range from 2 to 4. It simply shows that there's a varying performance of different facilities in implementing management practices. Next slide. So actually, we are conducting a study in view of the shortage of research from low-income countries. Actually, we couldn't find a lot of research linking management and neonatal mortality. We, through the IMPRESS project, we are conducting a study whose primary research question is to examine the extent to which management practices affect the quality of care and ultimately reduce in-hospital mortality for neonates. Next slide. And basically what we have done is to design a multi-component intervention that focuses on continuous improvement, applied them to hospitals, and these are the interventions that the hospitals have management control on, and we're conducting a cluster randomized study in which the intervention, this multi-component intervention, has been assigned to 10 intervention hospitals. These are the hospitals that are implementing the NEST interventions, and we have 20 control hospitals. And these interventions, we implemented them from July 2023 to July 2024. And basically, we support these hospitals to implement a set of management practices through visits to these hospitals by technical assistance. They visit these facilities once in a month to support them in the implementation of management practices. Next slide. This just shows the intervention, how it's been delivered. Basically, we started with a diagnostic phase in these 30 hospitals, where we devised a management improvement plan. And then we implemented the plan over the period of 6 months. And then later towards the implementation period, our support by our technical assistants reduced to allow the hospitals take charge of the management improvement practices. Next slide. The key outcome of this cluster randomized study is to assess the impact of the management practice on neonatal. A set of secondary objectives, which is looking at the quality of care, really answering the question whether the management practices that we hope are improving will affect mortality and also neonatal quality of care. And we're using the neonatal inpatient data set from the NEST 360 to collect the outcome. And basically, this has a comprehensive data set on the quality of care for the neonates and also on mortality. But in terms of monitoring the management practices, we conduct periodic hospital management survey, and also we are monitoring the uptake of the management practices. Next slide. So besides looking at the outcomes, but also we are looking at the level to which the management implementation plan is being implemented. We're looking at fidelity in the implementation of the management plan, but also we are understanding what factors affect the successful or unsuccessful implementation of the management plan. We are also looking at the mechanisms by which the management plan improve the outcomes, i.e. neonatal mortality and also quality of care. Next slide. Our preliminary results are shown on this graph. Most of the hospitals in the intervention arm, and this is actually showing the interventions, the adoption of management practice in the intervention arm. In blue, light blue is the baseline, and each hospital stated the target to which they want to improve the management practices. As you can see, most of the hospitals have improved their implementation of management interventions over the period of study implementation. Next slide. So at the moment, we don't have the results as to whether the intervention, you have seen an improvement in the implementation of management interventions. But the next question now, we are analyzing data to see whether these improvements were associated with improved quality of care and reduction in neonatal mortality. And the findings are expected in September 2025. If we don't see improvements in the quality of care and mortality, we are doing a process evaluation to examine the barriers that prevented the improvements. Or even if we see the improvements, we would like to establish the mechanisms by which the improvements occur. Next slide. So basically, this is our references, and then the acknowledgement slide. We'd like to thank the Ministry of Health that is supporting this study. As you see, that is focusing mostly on management practices, which are important for delivery of care. So we'd like to thank the hospitals and all the technical assistants who are delivering this management intervention. Thank you very much.
Thank you very much, Professor Mwapasa. And we're also delighted to know that not many studies are done in this domain, and you're leading the field there, an African country leading the field. Wonderful. So our next talk our speaker is Dr. Rajesh Mehta, and he hails from India, our continent, South Asia. And Dr. Rajesh Mehta is an adjunct professor in public health with 40 years experience in newborn and child health at country, regional, and global level. He's a fellow of the Indian Academy of Pediatrics, a former regional advisor at the WHO Regional Office for Southeast Asia, and he's provided strategic advice and support to 11 countries within that region to strengthen newborn, child, and adolescent health programs. But I think most importantly, Dr. Rajesh Mehta is also a QI champion and an expert. He's led and coordinated the regional quality improvement models in the Southeast Asian region that has been introduced in other regions. So Dr. Mehta, we look forward to your talk. Over to you.
Thank you. Thank you so much, and my pleasure and my thanks to the organizers to invite me to this webinar. So taking forward on Victor's premise that governance at the hospital level would have beneficial effects on quality of care and leading to mortality reduction and morbidity reduction. Next slide, please. So let us examine that how leadership is critical for quality of care improvement. When we set up the Quality, Equity, Dignity Global Network on Quality of Care about a decade back, leadership was clearly the first premise that we must have leadership with us from countries of the network, essentially ministries of health, so that we could demonstrate, a concerted effort. But setting the vision, creating the environment for quality of care, and fostering collaboration across the stakeholders, leadership is really important. Next, please. So leadership is essential for quality of care at multiple levels of health system. At the macro level, which is largely operating at national level and state level, or a province level, these are ministries of health where there is a unit who are responsible for quality of care. That leadership is critical. Then at meso level, many decentralized situations in the countries, district level, in some places it is called province level again, we need the second level of leadership. And at the micro level, which is health facility or a big hospital, which is the cutting edge of the healthcare system, the point of care where doctors and nurses and teams meet the actual patients, the third level of leadership is required there. Next, please. And all of these leadership at different levels must keep talking to each other so that we have system-oriented, system-wide approach to ensure quality of care and the desired health outcomes. Next, please. So moving our attention directly to health facility or a big hospital, I would like to make a distinction. In our part of the world, at least in Asia, I'm very familiar. Healthcare system is a very hierarchical health system. There are levels of leadership within the hospital. For example, if there is a big hospital, the director or the manager or the administrator is the one person who is accountable for service delivery and should be held responsible for providing quality of care, patient-centric care, and maintaining the operational efficiency. But then there is a head of the department, then head of the unit. For example, neonatology, there is a head of department, and within the department there are few units, and each unit head also is critical link in the leadership. Next, please. So from that aspect of the governance at the hospital level, as Victor was suggesting, the 5 domains of good practices of management. These are the principles on which the leadership actually should support the teams with adequate resources and actually building a culture of quality. Next, please. So in addition to the governance, the top leadership of the hospital in a big hospital setting, at the front line, we need another kind of leadership, which is actually determined by the clinical healthcare team who are trying to provide the best evidence-based care to the child and the family, the newborn family, within their routine practice. So therefore, a clinical care team has to have a leader for a quality improvement area where they are trying to fill in the gaps, and therefore this kind of qualities are important in a clinical healthcare team where leader values the inputs of others in the team and actually does not think that he or she knows everything and actually takes ideas from the team. So leadership at the cutting edge level is also clearly important. Next, please. So here I would share with you an example. While the leadership in the hospital will do several things to promote quality of care, right from accreditation work, providing all the infrastructure, clinical audits, death reviews. And this is one of the examples where we tried in our region to reduce the knowledge practice gap within a healthcare team concept. That is there a stepwise problem solving approach where a local team using local data from their own daily practice and try to actually determine if the process of care is designed well to lead to the desirable health outcomes. So there is a stepwise approach which is being simplified in our region, and this is called point of care quality improvement. It's a problem solving common sense approach. A local leader with the team, local clinical care team, uses the local data to define the problem and then determines the measurement indicators, both process and outcome indicators of care, and then do a rapid implementation cycle to test whether the change ideas are working or not. So it's very well-known concept, but simplified. So these are the documents or the resources available. I think they are also available in NEST 360 Toolkit. If they are not, I will request Joy to kindly include all these materials. They are very easy to use and have been used widely. Next, please. So using this process, by now we have more than 150 odd peer-reviewed publications using this 4-step simplified approach. On my left on the screen is an example from Kolkata in India, where in the labor room, they achieved 80% practice of clean delivery care within 2 months by improving the process of care. Of course, they filled in the knowledge gap, but also brought in all the cleaning material next to the delivery table and ensured that each time a delivery table is cleaned, the hand hygiene, and they improved the infection prevention practices. The next one is from Myanmar, where they use this 4-step process to improve early essential newborn care at birth for all newborns. So they could achieve universally. Actually, 100% babies received essential elements of the newborn care at birth using this problem-solving approach. The next one is from Indonesia, where they actually introduced pulse oximetry screening for critical congenital heart disease immediately after in the postnatal period. They introduced this new service, and they use PDSA cycles using this spooky approach to actually achieve 79% or 80% compliance with the pulse oximetry screening within 3 months. Next, please. So these are big hospitals. So where the leadership would be, acting in consonance from the top director management level of the hospital to the neonatal unit and to the frontline team. And this is the next set of examples from the district level 2 newborn care units in India. I told you there are more than 100 publications, but I wanted to say that, for example, rational use of antibiotics to prevent antimicrobial resistance was achieved in several newborn care units within the district using the local leadership and the 4-step process which I described. Similarly, by introduction of a essential step in the process of care of measuring oxygen saturation, they could reduce the unnecessary use of oxygen in a newborn care unit, and which led to safe use of oxygen, but also saved them money. Similarly, prevention of hypothermia and initiation of enteral feeds early in some of the newborn units. So I should mention that many of these projects were actually led by nurse leadership. It's not always that the doctor or head of the department or head of the unit will provide the leadership. For each quality improvement project, it will be an appropriate person who would be chosen as leader, and nurses have performed rather well in our context in India and neighboring countries. So that's how the leadership is so critical. Next, please. So if we didn't have leadership involvement, we would have a lot of trouble in delivering good quality care. There would be fragmentation of QI efforts. The system approach would be missing. It will be difficult to sustain the champions of quality, even if they wanted to. A weak leadership or a negative leadership could prevent that. So we have a lot of problems if there is no leadership within the healthcare system, right from point of care to the top. We must have everyone working together. Next, please. So I must remind ourselves that poor quality has really high costs. And we have seen that that many lives are lost because of poor quality of care. So I would stop here and will wait for any questions if they are there. Next, please. And with that, I must also encourage each one of us that all of us can actually lead quality of care. But remember, my definition of leader is who can produce more leaders. So I quote from this person that you are not a leader until you have produced another leader who can produce another leader in due course. So I'm so optimistic that all of us can actually lead quality of care for newborns, which are a vulnerable part of our societies. Thank you so much.
Thank you, Dr. Mehta. And I like that last slide where we're creating more baby leaders from one to the other, like the babushka dolls. Okay, so we are taking questions at the end, but we now need to move on to our third talk and our third continent. So can I introduce you then to Dr. Sonia Venancio, who's from Brazil. She's a pediatrician. She's got a PhD in public health, a researcher and a general coordinator of healthcare for children, adolescent, and the youth. And she works at the Ministry of Health in Brazil. Thank you, Dr. Sonia. Hand over to you.
Thank you, Dr. Rhoda. Thanks for having me. It's a pleasure to be in this meeting and share with you some good news from Brazil. First of all, I'd like to share a brief overview of our country. We are the 50th largest country in the world, and we are organized in 27 states and more than 5,000 municipalities. We have a public universal health system in Brazil. We call Unified Health System, SUS. And with 52,000 family health teams, we have at this moment a coverage of more than 80% of the Brazilian population. However, despite the advances, we face great challenges like reducing neonatal mortality. We have at this moment 8.5 per 1,000 live births in Brazil. And we also have a high prevalence of preterm births, around 12%. Next, please. So in Brazil, kangaroo care is a national health strategy that integrates a set of actions aimed at improving the quality of care for newborns, their parents, and family. Next, please. And kangaroo care is part of the National Policy for Comprehensive Child Health Care since 2015, and it contributes with the humanized care to pregnancy, childbirth, and newborns. Next, please. So kangaroo care is implemented in Brazil in 3 phases. The first phase starts in prenatal care when we detect a high-risk pregnancy. Then we go to the neonatal intensive care unit, and after that to the conventional intermediate care unit. The second phase is implemented at the kangaroo intermediate care unit, where mothers stay all the time, every day, with the newborns being prepared for the discharge. And the third phase is implemented at home and in the follow-up of the babies. And this follow-up is shared between specialized care and primary health care. Next, please. So about the implementation, next. The implementation is coordinated by Ministry of Health. We have a management committee that is composed by members of Ministry of Health and external advisors, and we support 5 national reference centers. At the state level, the state health departments support 27 state reference maternities. And we work with a decentralized support. We have around 1,000 tutors that are professionals trained to support the implementation of kangaroo method in every state. Next, please. We also have some technical handbooks and videos to help kangaroo method implementation, as you see in this slide. Next, please. And we also offer some training courses, in-person training courses and online courses too. And these courses, the objective is to train tutors to support the implementation and health professionals that are working at the maternities. Next, please. So at this moment, we have 33 maternities with all the 3 phases implemented. 303 maternities with kangaroo beds, 1,548 kangaroo beds implemented, and 1,116 kangaroo beds with financed by Ministry of Health. Next, please. Now I'd like to share with you our new financing since last year. Next, please. We detected a deficit of kangaroo beds in Brazil. We have a deficit of beds in all the units, so a deficit of 302 beds at the neonatal intensive care units, 516 beds at the intermediate care units, but a deficit of 1,132 beds at the kangaroo intermediate care units. And this can be explained at least in part because we had funding, a very low funding for kangaroo beds until last year. So next, please. So in this new financing, we decided to increase the funding to kangaroo beds to expand progressive care. So we had an increase of 240% in the values that are paid by Ministry of Health to the states and maternities. Next, please. So you can see these values in dollars. We have now the same value to intermediate care and kangaroo intermediate care. The same value is paid. And so we are expecting we can increase the number of kangaroo beds in Brazil. This is the value of the daily rates we pay to the maternities. Next, please. And about the monitoring of coverage, next, please. We have at this moment a coverage of premature births under 35 weeks in hospitals with kangaroo beds in the last 7 years, a coverage of 44.5%. And we are expecting with this new funding, we can increase and expand the kangaroo method in Brazil. Next, I think this is the last one. I'd like to thank you, and I'm here if you have any questions.
Thank you, Dr. Sonia. And I think you've just proven it's really important to actually do the gap analysis to see how many beds you have, and specifically for kangaroo, because we're fond of pricing and costing the NICU beds, but we pay little attention to the beds that are actually taking the bulk of the patients. Okay, so we're going full circle back to Africa, and I want to welcome the speakers from Kenya on the fourth talk. It's our biomedical engineers. Next slide. So yeah, thank you. So could I introduce you then to Millicent Alooh? She's a biomedical engineer, and she's currently working as the regional director of the Biomed implementation for NES 360. She also serves as the Honorary Secretary General for the Association of Medical Engineering of Kenya, and she's also a member of the Global Clinical Engineering Alliance. Millicent is a strategic advisory member of medical devices at WHO and a medical device policy review committee member at the Kenyan Bureau of Standards. And she's joined by her colleague Marvin, and Marvin is a senior medical engineering technologist who's based in Kakamega in the western part of Kenya, and he coordinates medical engineering services at the Kakamega County Referral Hospital in the larger county. So to my Kenyan colleagues, you're welcome. Please, you may start.
Thank you so much, Dr. Natasha. Yes, so we have heard about the leadership, the quality improvement, and the management practices, and a lot of changes that have taken place in different countries. And so we'll be taking us through leadership change at the hospital level, that is at a very micro level. and what the biomedical engineers can actually do at the hospital level to bring change that are able to impact the care of our vulnerable newborn. Next slide, please. Yeah, so a number of times we have seen the role of biomedical engineers at times overlooked and at times really taken so keenly, especially when it comes to the care of newborn babies. And so we'll be looking at the roles of biomedical engineers in the hospital in this particular slide, just an overview. So the biomedical engineer's role in the hospital is majorly concerning the management of medical equipment from the beginning of the planning all the way to decommissioning. And that is basically the service life cycle of the device, the installation, the operation, all the way to the disposal of these devices. And so if you look at the health technology management life cycle that is displaying on the screen, you will see that there are 9 phases of medical equipment life cycle. And all these phases, a biomedical engineer is very keen in giving the technical advisory on the right devices to be purchased for our newborn babies, on the right technical specification, on the kind of training that is required for both users and the technical team, and even the amount of budget required for the accessories, consumables, and spare parts. And so I will not be going through each and every phase for today, but I just want to mention in this particular slide that there's really a need to utilize the existing national and facility guidelines on the maintenance of the biomedical equipment at the facility level, more so on the devices that are supporting our newborn babies. And so today we are going to have a case study of one of the hospitals in Kenya, and that is Kakamega County Referral Hospital. And we are going to narrow down or rather have a deep dive on how decommissioning of the devices was done in this particular hospital to ensure that the devices that are obsolete, or rather the devices that have reached the end of life, are not causing any hazard to the environment. Because we know in the low and middle income countries, we have a lot of problems with the devices that we get in terms of having graveyards or junkyard, as a number of us call them. And so I will welcome my colleague, Marvin Nandwa, to take us through what he did as a biomedical engineer at the Kakamega Hospital to be able to ensure that all the devices are well taken care of. And for those ones that have reached the end of life, because all the devices will, at any given time, are decommissioned well and disposed in accordance to the guidelines and procedures of the country. And so allow me to welcome Marvin, and you can go to the next slide, please.
Yeah, thank you so much, Millicent. I'll pick up from this. Many a times, each and every equipment that is procured definitely has a lifespan. And the moment this equipment is used beyond its lifetime, then becomes obsolete and needs to be disposed. And as biomedical engineers, one of the key things you'll do at that level is to decommission this equipment from use. And the next line after that is disposal. And that's why this moment I want just to discuss this case study of Kakamega County Referral Hospital on obsolete equipment management. So definitely obsolete equipment is just, these are equipment that are beyond economical repair, hence to be disposed for replacement. And the process requires a coordinated effort between biomedical engineers, the finance team, supply chain management team, each of them having their various roles to play in the disposal. So this, the picture you're just seeing on the right side, this was the case at the Kakamega County Referral Hospital in March of the year 2021. Next slide. So the hospital will have to take an initiative to be able to dispose some of this obsolete equipment, which was becoming a nuisance to the facility. So one of the key things we did was to do an assessment. This assessment entailed just bringing on board everything that is beyond use, clinical use, economically cannot be repaired. So all this was decommissioned from active use and placed in a central place. So these were able to prepare a list of all these items, and this was presented to the hospital management. This actually led to a formation of a hospital disposal committee, of which it was chaired by the medical superintendent and the biomedical engineer becoming the secretariat to that committee. So this committee was able now to analyze the list of all this equipment and was able now to do a comprehensive report towards that. And considering all these assets in a government health facility, we also needed clearance to have this disposed. So this report from the committee was forwarded to the county assets and disposal secretary, who was able to do validation, and this led to a valuation team being formed, and this was now entailed the finance team, a supply chain team, who are able now to do valuation of all the devices, the equipment that are obsolete beyond use, and they were also able to do their own report. And this entails now to come about costing in terms of as much as you are disposing, if there is any revenue that can be gained from those assets as they are being disposed. So the process actually led to the county now realizing this can be done in all the other county agencies, including the health facilities and all the other ministries. So this was done, and an open tender for this was done later on in the same year with a service charge of about 10%. Which led now to all these items being collected, and they were disposed with the service charge becoming a revenue to the county. Next slide, please. And you can see now on the right side the state of the same spot after that disposal. So one of the key achievements led to all this obsolete equipment being disposed. And during the decommissioning process, it's also important to note that as biomedical engineers, we are able to harvest some of the key spare parts that we felt could be used in other similar model of equipment in terms of repairs and spares. We're able to do that. And also during the disposal, also a mechanism was used whereby learning institutions were invited as well to come and pick some of those equipment that could be used in the learning institutions, but could not be used clinically on patients. So equipment replacement mechanism in place was put in place actually, and this also led to having a budget line to be able to replace all the equipment that were decommissioned from clinical use. Next slide. Yeah, so thank you. And I just want to part short by saying for the medical engineers, it's very key to ensure rather all the devices that are obsolete are disposed, because without that, it portrays now a negative image to the facility and the biomedical engineers in terms of lack of maintenance of those equipment. Yeah, thank you so much.
Thank you, Marvin and Millicent, for cleaning up the hospitals. So I'm guessing goodbye graveyards and more space for kangaroo mother care, or kangaroo care as we call it in Brazil. So fortunately, we've stuck to very good time. So we've got time to ask a few questions. And I see Professor Mehta has already answered 2 questions, but there's a question open, and it's to Dr. Sonia from Brazil. It's from Professor William Mancharia from Kenya. And he, first of all, congratulates you on your very low neonatal mortality rate of 8.5 per 1,000 live births. But he wants to know, how has kangaroo care impacted this, especially in the hospitals where the 3 stages are already implemented for a long time? And that's the first one. And the second part of that question is, what other complementary interventions are there besides kangaroo care to get your NMR to less than 10? Dr. Sonia, did you get that?
Yeah, thank you. We calculate this deficit according to the percentage of preterm births we have in Brazil. So I showed you we have now a coverage of 44% of preterm babies born in maternities with kangaroo beds. And we have around 1,000 kangaroo beds implemented. So we estimate that we have to expand 1,000 more beds to attend these preterm babies in Brazil.
Okay. William, did you get to the nub of your question? Perhaps, Sonia, if you could also type your answer, it'll be of benefit to everybody else. There's another question here posed to Dr. Mehta from Nebiu. It says, thanks, Prof. Mehta. What key areas should meso and micro level leaders focus on while leading improvement activities beyond resource allocation? And specifically, what aspects or actions should they take the lead on?
The best they can do is not to prevent people for actually adopting QI approaches. So many times, there is a barrier that a leader, administrator who is not, in sync with the need for quality improvement or the need to invest in quality improvement ends up stopping a champion from practicing this. So they don't give permission. What we have done is that we have actually engaged with clinical leadership to actually make them better oriented and more convinced, so that at least they support the activities of the team, the healthcare team within the facility, to show them that without asking for additional resources, they can make improvement by adopting certain changes in the process of care, and that leads to better outcomes. So the idea is that a national level guidance with the all the provisions as a part of policy, the meso level leadership has to translate that into the field area, and then the local leadership is required to actually allow use of better quality approaches to conform to evidence-based care. So there are a lot of components within the leadership area, including good communication, resources, of course, but also talking with all stakeholders and making a partnership, involving the families and communities. So all of those are important. As you go down the line, the guidance has to be converted into practice. So that's how gradually we can build on this work culture of quality of care in facilities.
Thanks, Prof. Mehta. There are two questions regarding equipment in particular, so I'm going to put that to Millicent. Millicent, Prof. Velapi in South Africa is asking about the lifespan of the equipment and how that's determined, and how do you ensure oops. I think Joyce answered the question to him. Joyce says the lifespan is determined by the size and type of device. For large devices, it's estimated at 4 years, but will vary with doing routine care of devices. There's more in the webinar. Okay. So, Victor, you're asking, is there a national policy of disposal of the equipment, and who bears the, yeah, Millicent or Marvin? Could you answer that question? It's in the webinar chat box.
Yeah, sure. Sure. So let me start by saying yes, there are national policies, different national policies depending on the country. So each country has their own national policy for disposal of equipment. And a number of times, they're actually lying somewhere, not really in use, and you can actually also get them through the Ministry of Health websites. That is where we've been able to get a number of them. However, apart from that, WHO has a global policy for disposal and decommissioning of medical devices. It would really be very helpful, especially for the countries that probably may not be having the national policies for disposal of devices. So in the event you do not have, please, you can go ahead and use the WHO one, which is available in the WHO website and free to load. Thank you. Over.
Thank you. I see there's a question for, keeps on jumping, Dr. Christ. Thank you very much for the webinar. Could you share the presentation? Yeah, we'll share that, Beatrice, don't worry. Perhaps I could ask Professor Mwapasa, in those 5 domains and 28 practices, I know your results are coming out in September. Was there any sense from your study group that some had more weight than others? So for example, in the 5 domains, the leadership versus the HR, the target, the clinical care, and the cost, were any one of them more important than the other in the preliminaries? Were they weighted the same?
No, but I think there were ones which were proximal to the
I think we've lost Prof. Hello? Can you hear us, Prof? I know, Prof.
Sorry, I lost the internet. So they have different weights, and basically they were weighted similarly. But I must say that the ones that were closer to quality of care and mortality was the delivery of clinical care domain, which looks at the management capacity and skills in the neonatal unit. The rest of the domains were kind of distal, away from the neonatal unit, mostly like human resource management. So they were all equally weighted when we were actually calculating the average score. But in terms of a prediction of quality of care and mortality, the delivery of clinical care domain was considered to be more proximal and maybe more important, at least in the views of the hospital managers. Thank you.
Okay, thank you very much. I see there's some questions also for Dr. Sonia from Brazil. I think one of them is a quick one. Do you use reclining chairs for KMC or just beds? And the second one is, at what weight do you discharge your preterm babies? Dr. Sonia?
Okay, thank you. Could you repeat, please, the questions?
Yeah, at what weight do you discharge your preterm babies? At what weight? In kilograms? How big are they when you discharge them?
Okay, they are the discharge with 1,800 kilograms.
Okay.
And we follow the babies at the specialized care. We have services to follow up until 2,500 kilograms. And this follow-up is shared with primary health care, because the primary health teams also follow up these babies together with the follow-up services.
Okay, thank you. So the facility discharge weight is 1.8, and from the follow-up in the community, if they're well, it's 2.5 kilograms. Thank you for that. And reclining chairs, are you using reclining chairs or are you preferring KMC beds? Okay, that's fine, Dr. Sonia. You can type that answer. If you allow me, we've got a minute to go. I just wanted to thank all our speakers for really giving us such valuable insights into how we can change things, specifically if we can just summarize quickly, specifically that Professor Mwapasa has shown us that management is actually really important. We know the bottom-up approach and the top-down approach, but we mustn't forget also the leadership in the middle. And not only do we need leadership, but we need leadership who actually speak to each other. So that's really important. And as a follow-on, I've now learned a new word. It's called POCQI, POCI, point of care quality improvement. It's tried and tested, lots of publications. Please have a look at that on I think the links have been sent to you, the 4-step and simplified way of a tried and tested way to ensure that this happens. Dr. Sonia, I think lots of questions to you because Brazil has got an amazing neonatal mortality rate, despite having quite a high burden of prematurity. And then thank you to Millicent and Marvin for showing us that we can get rid of those graveyards. So the slide that you've got up now is just showing you the QR codes. But thank you for joining us. And we once a month watch all the media so we can send it to you. And remember, we're also in French, so everything is available to the Francophile countries as well. And we look forward to 11 more of these fora where we can discuss really topical issues in neonatal care, not only for Africa, but for the whole of the world. So thank you, everyone. And it's 4 o'clock. We're going to call it a day. Thanks very much. Have a good day. Have a good evening.